Thank you very much. Good evening, all. We have a well-balanced scientific program for ResFire 15, and this is endorsed by European Respiratory Society, Malaysian Thoracic Society, Indian Chest Society, Bangladesh Lung Foundation, and also Pakistan Chest Society. This scientific program has 6 symposia and 6 guest lectures. And almost all the speakers are from overseas countries. And thank you very much all for sharing your knowledge and experience with us. So we thought of being the organizing committee, putting this science into practice. Therefore, it is time to discuss real life cases. So this time, the program is named as ResFire. So we have 2 sessions of ResFire. The first one regarding challenging respiratory infection, and tomorrow interstitial lung diseases. So today the moderator and the panel know about the case, and tomorrow it is really blind. Only the moderator know about the case. So for the today's session, I would like to invite to moderate the session Dr. M Athavan, consultant respiratory physician. For the expert panel, Dr. Bandu Gunasena, consultant in respiratory medicine. Professor David Denim, Professor of Infectious Disease, Dr. Sumana Handagala, Consultant in Thoracic Surgery, and Dr. Mahen Kotalawala, Consultant Microbiologist. Over to you all. Thank you.
Good evening, all of you. Today we are going to explore 2 interesting cases of complex pulmonary infections. Without further delay, I'm going to proceed for the case discussion. This is our first case. We have a 65-year-old male who has multiple comorbidities. He's known to have diabetes type 2, hypertension, and he was an end-stage renal failure patient requiring renal replacement therapy. And he's also a chronic wheezer since childhood. His symptoms were partially controlled at the time of admission. He received a transplantation of the renal allograft from a deceased donor. After the transplantation, his urine output was quite good on the first 24 hours. However, after 24 hours, there is evidence of allograft dysfunction with reduced urine output, leading to severe oliguria by 72 hours. He was treated with methylprednisolone pulse therapy 1 gram daily for the first 3 days and 2 doses of basiliximab on day 0 and day 4 to prevent transplant rejection. This was followed by prednisolone 20 mg daily and tacrolimus 3 mg twice daily. And he was also started on cotrimoxazole and valganciclovir to prevent transplant-related, immunosuppression-related opportunistic pulmonary infections. However, on the postoperative day 2, he developed a severe acute abdominal pain. This was associated with nausea and vomiting. The diagnosis of an acute pancreatitis was established with raised serum amylase and a sonography of the abdomen showing edematous pancreas. On postoperative day 3, he developed increasing respiratory distress with increasing shortness of breath. His inflammatory markers were raised. His CRP was 200 and his serum procalcitonin was 1.1, which was raised. This was his initial chest X-ray, which was performed as a part of a preoperative lung assessment, pulmonary assessment. This was normal. When the chest X-ray was repeated, when he developed increased respiratory distress, it is mostly normal except for some infiltrates on the bases near the costophrenic angles. He also complained of increased cough, shortness of breath, and wheeze. On chest auscultation, there is bilateral polyphonic wheeze, and his work of breathing was increased. His lung ultrasound scan showed collapsed, deaerated lungs in the both bases with inflammatory type of pathological B lines in the posterior basal lung field with mild pleural effusion on the right side. He underwent non-contra CT chest. His respiratory failure progressed over the next few hours. He initially required conventional oxygen therapy as a respiratory support and then required high-flow nasal oxygen therapy. This is his non-contra CT chest. You can appreciate most of the lung fields were normal, except for the extreme basal lung field, where you can appreciate collapse consolidation, and there is mild pleural effusion on the right side. So, what is the likely reason for the respiratory deterioration? May I pose these questions to Bandu sir?
Yes, thank you. Well, it is an immunocompromised patient, renal transplant. So he has a pancreatitis also. The patient is rapidly seeing BQ mismatch in the lung, some form of consolidation, fluid collection. We would think of probably can go into ARDS, but the patient with the immunocompromised state, I would consider bacterial sepsis causing pneumonia. And pancreatitis-induced ARDS also is a possibility. But anyway, management is anyway supportive. So I would rather go for a broad-spectrum antibiotic in this patient.
Yes, so in addition to the fact that the imaging finding he has on auscultation, there is bilateral polyphonic wheeze. He's a non-asthmatic.
Yes.
There were clear evidence of exacerbation of ARV disease.
Yes.
So his respiratory, as Sir correctly said, we thought it is could be due to ARDS and as well as ARV disease exacerbations. And we were also not sure whether there is a component of early onset nosocomial pneumonia. So we empirically treated these patients with a combination of IV piperacillin tazobactam and teicoplanin, because this patient is being hemodialyzed and there are multiple risk factors for methicillin resistant staph aureus. So we empirically covered for methicillin resistant staph aureus with IV teicoplanin. His clinical condition started to improve with reducing inflammatory markers and improving early warning score parameters. His respiratory rate improved, his work of breathing improved, his tachycardia improved. However, on the day 7, he developed temperature spikes with rising inflammatory markers again. His CRP and the procalcitonin rose to CRP rose to 200 and the procalcitonin has gone to 14. And when we perform the lung ultrasound scan, again, there is evidence of progressive infiltrations. And this time we could able to appreciate an inflammatory type of pathological non-confluent B lines on the upper and lower blue point, and there is collapse consolidation on the bilateral PLAPS points. And his CT chest was repeated. You can clearly appreciate the progression of the infiltrates compared to the initial CT. So there is more extensive infiltration on both sides compared to the initial CT. Also, there is evidence of worsening oxygenation as his PF ratio was going up while he was on the high flow nasal oxygen therapy, and his FiO2 requirement was increasing, his work of breathing was increasing, and the inflammatory markers were further rising, and he required endotracheal intubation and invasive mechanical ventilations. So, Bandu sir, what do you think is the likely diagnosis at this stage?
Yeah, still it could be some resistant organism which we are not treating adequately, or some another pathogen like a fungal infection, virus unlikely because the consolidation is appears much more demarcated with effusion at the beginning. So I would ask my biology colleagues about the changing antibiotics and consider antifungal.
So this patient developed progressive pneumonia while on optimum antibiotic treatment as for early onset of nosocomial pneumonia. So we thought that this is very likely a late onset of nosocomial pneumonia, possibly due to a resistant pathogen which is not responding to the empirical antibiotic that he is currently on. What empirical antibiotic therapy should we choose while awaiting culture results? May I pose this question, sir? Mahen, sir?
Right. Thank you very much. Now, this is a very interesting case with a hospital-acquired pneumonia. And initially, the patient was treated with teicoplanin and piperacillin tazobactam, which had been basically targeting Staph aureus and gram-negative, maybe Enterobacteriaceae and other pseudomonas. And in spite of those antibiotics, patient is not improving. There may be initial improvement followed by a deterioration. So I would think more or less an organism causing hospital-acquired pneumonia, which is not covered by the initial therapy. And in our scenario, it is basically Acinetobacter. So therefore, I would try to start on something like ceftriaxone sulbactam at a higher dose with colistin. So that would be covering basically the both predominant pathogens which causing hospital-acquired pneumonia. Yeah. And in the meantime, after taking the specimens, I would come back and review our choice with the microbiological investigations.
So how useful is a BioFire Filmarin pneumonia panel in this setting? It's to guide our decision on our empirical antibiotic therapy. Yes.
Yeah. So, I can't exactly say its usefulness in Sri Lankan scenario because it is very costly to operate and it is not available frequently except for 1 or 2 private hospitals. It is not available at all for government sector patients. But as a test, it's a very good test with a high ability to differentiate certain pathogens. But there are certain drawbacks. One is the specimen. So the specimen validated for BioFire is the upper respiratory specimen. And although it is validated for upper respiratory specimen like nasopharyngeal swab, it can be performed on lower respiratory samples as well. And it is useful, for something like 22 odd targets, more viruses and less bacteria. And it gives a rapid result within very short time. But again, as I mentioned earlier, it is the cost. And I would happy to go for more conventional microbiology than going straight away for tests like BioFire or something.
Yeah, so the one advantage of the BioFire PCR, what I believe is that it helps us to know whether it's a Acinetobacter. The second common pathogen in Sri Lankan ICU, and ICU is causing late onset of nosocomial pneumonia is the
not exactly.
E. coli and Klebsiella.
Not exactly. The panel doesn't have Acinetobacter.
I believe it has. Acinetobacter bomani is included.
2.1 respiratory panel, it doesn't have Acinetobacter. It basically community-acquired pneumonia pathogens, as far as my knowledge.
And then it also can detect.
Yeah,
it can also.
I think it's a community-acquired pneumonia panel. So the chances of Acinetobacter including in the panel is less. I don't know if anyone can answer that. I think it's designed to detect community-acquired pathogens.
Yeah, but it can also detect the carbapenem resistance.
Maybe a different panel. So just now I had a look at it, and it's basically the other panels.
Pneumonia panel, yeah.
So it has 4 bacterial organisms.
No, it has 14 organisms, isn't it? Yeah. So the one which is available in Sri Lanka with Asuri Hospital is 14. Yeah. So in our ICUs, the 2 common pathogens which causes nosocomial, late onset nosocomial pneumonia are Acinetobacters and coliform organism, either E. coli or Klebsiella. So these are the 2 common organisms. So we wanted to cover these with ceftriaxone sulbactam, as Mahen said. And since this patient has renal impairment and allograft dysfunction, we preferred polymyxin B, but however, the patient needs to purchase this from the private pharmacies instead of colistin. So his sputum culture results became available after 48 hours. It isolated a mixed growth of Klebsiella and Acinetobacter. Both were sensitive only to polymyxin. And blood culture isolated in multi-drug resistant Acinetobacter, which is again only sensitive to polymyxin B. Would you consider opportunistic pulmonary infections in these patients? May I direct this question to Professor Denning?
So he has several risk factors for fungal infection. He's immunocompromised because he's had a transplant. He's had bolus steroids. He's got pancreatitis. He's got previous lung disease with his wheeze, which increases the risk of aspergillosis. And now he's had 4 antibiotics. And he's got prophylactic cotrimoxazole. So every class of antibiotic increases your risk of candidemia. So does pancreatitis. So the answer is definitely he's at risk. The question is what to do. So the one infection I think is unlikely is pneumocystis pneumonia. The pattern of disease is not typical. He's got a lot of inflammatory markers, and he is on prophylaxis with cotrimoxazole. So that's less likely, although it's not zero because there are resistant cases out there. So does he have candidemia? Does he have invasive aspergillosis? And then this group is less likely to have mucormycosis. He is diabetic, but he's not out of control, I assume. But it isn't a zero risk because they do get, some solid organ transplants do get mucormycosis. So my concerns here are some form of invasive candidiasis, candemia, or invasive aspergillosis.
Okay, so we thought that since this is 7 days from the transplantation, which is the early days, and if you look at the timeline of the solid organ transplant related infections, within the first 7 days, the common pathogens are nosocomial bacterial pathogen. Of course, that other pathogens like if the patient is previously colonized with Aspergillus or other pathogens, it could cause invasive disease early in the illness. However, it is not common in the first few weeks of the transplant for somebody to develop opportunistic.
I agree. It is early. It's certainly early for invasive aspergillosis.
His sepsis showed signs of improvement after 48 hours of change of antibiotic therapy. Temperature spikes completely resolved after 72 hours, and there is marked improvement in the oxygen evident by reducing PF ratio, and there is dramatic drop in the inflammatory markers. CRP dropped from 245 to 104, and procalcitonin dropped from 15 to 4.2. He was successfully extubated on postoperative day 11 and weaned to high-flow nasal oxygen therapy. However, on postoperative day, so he was extubated on postoperative day 11, and on postoperative day 16, his temperature spikes restarted again. And he again became unwell, tachycardic with mild hypotension. His lactate was raised, which is 4.5 millimole per liter. His inflammatory markers were rising again. There is no significant difference in the respiratory. His FiO2 requirement was unchanged. His work of breathing was unchanged. And there is no significant difference in his respiratory status. And his chest X-ray doesn't show progression of the infiltrate. The endotracheal aspirate, which was sent before extubation, isolated Candida species. And the urine culture isolated Candida species. Should this patient receive antifungal therapy as for candidiasis? Because the isolation of the Candida from a sputum sample, because Candida is not a common pathogen which is causing pneumonia, we generally disregard this. Should this patient receive treatment as for candidiasis? May I direct this question to Mahen, sir?
So he certainly doesn't have Candida pneumonia. That's not a problem. You just as an aside, you may not know that the original work that was done with ambisome in the early 1990s enrolled lots of patients with pulmonary candidiasis, none of whom had candidiasis. They just had Candida in their sputum. This was in Europe when we didn't fully understand the disease. So the drug was licensed for the wrong indication to begin with, which is quite interesting because we don't remember that these days. It's forgotten, I think. But a urinary isolation is much more significant. So roughly 50% of patients with candidemia have a positive urine culture. And you can have a positive urine culture with invasive candidiasis with no positive blood culture. It can be a clue as to actually the actual diagnosis. The only trick here is that he's also been in ICU and he's had a catheter in probably since transplant, or almost not quite since transplant, since he went back to ICU. So you can get a catheter-related infection, which is not representative of invasive candidiasis. Chance of invasive candidiasis, in my view, somewhere close to 90%, not 100%. I don't know if you want to comment.
Yeah, thank you. So now, as mentioned, so the candida causing pneumonia is a very, very low possibility. But when you find candida colonized in non-blood sites, maybe urine or tracheal secretions or wound, and that is an indication of impending possibility to get invasive candidiasis. So considering this patient's scenario, the comorbidities, the renal transplant, and multiple antibiotics. So sometimes it is justifiable to start on anti-candida agent, thinking not due to pneumonia, but other sites, the possibility of infections from other sites originating from that. And in our scenario, it is mainly Candida parapsilosis, which is the one which is responsible for most of the invasive candidiasis, around 50%, not Candida albicans.
I agree with you, sir. So this is Candida score. This is not a formally validated score, but it has a moderate sensitivity and specificity in predicting the invasive candidiasis. So our patient has multiple factors of this score is being positive. For this patient has evidence of severe sepsis, the 2 points, and then the patient was not given total parenteral nutrition. However, the patient has an initial surgery, and there is evidence of multifocal candida colonization. The candida score for our patient was 4 out of 5, which is significant. A score more than 2.5 is considered positive. So it has a moderate sensitivity and moderate specificity in predicting the invasive candidiasis. So when the score is around 33, there is only 50% chance for the patient to actually have invasive candidiasis. But when the score is quite higher, when the score is 4 or 5, the probability would increase further. So subsequently, his blood culture confirmed candidemia. So his central venous catheter was removed and he was commenced on antifungal therapy, initially with fluconazole, as the anidilofungin was not available initially. And subsequently, he was changed to anidilofungin, which is an echinocandin group, which is the preferred choice for invasive candidiasis. So in all the patients with invasive candidiasis, the routine dilated ophthalmological evaluation is recommended because it can complicate with candida candida vitritis. And sonography of the abdomen was performed to look for deep-seated candidiasis, and which was normal. He became fever-free within 48 hours of starting anidilofungin treatment. His sepsis markers improved. He was transferred to the renal HTU 24 hours later, completed 14 days of treatment with anidilofungin. He recovered to hospital discharge 30 days after surgery. How effective is 1,3-beta-D-glucan in guiding empirical antifungal therapy? May I direct these questions to Professor Denny?
Not very helpful, generally. It's quite a good test for invasive candidiasis. It's a sensitivity around 80%, something like that, and quite a high negative predictive value. So if it's a negative test, it's less likely to be candidiasis in the ICU setting. It's also a very good test for pneumocystis pneumonia, and it's a pretty good test for aspergillosis in non-neutropenic patients. During neutropenia, it's not so useful. But does it fall with therapy? And the answer is yes, eventually. But it's not a terribly good test in guiding when to stop therapy, honestly. But what should be done, and I'm sure you did do this, is to repeat a blood culture about every 2 days in a patient on candidemia, because around 10% of patients do not clear their candidemia at all. And the reasons for that are not fully clear. Sometimes it's because they have endocarditis or another deep-seated infection, but those patients need a transfer of therapy. Here, I think you were successful clinically, which is fine, but the normal recommendation is to repeat a blood culture about every 2 days and know that you have cleared the infection, and then you can decide to stop therapy at that stage.
So one of the other questions that I have is that candidemia is seen only in half of the patients with invasive candidiasis. So in which case, if we have a high index of suspicions based on the clinical ground, so what we should do with the antifungal therapy? So if we couldn't be able to isolate candida on the blood cultures, what are the measures that we can take to isolate? So there is some evidence to suggest that performing multiple cultures, 4 sets of cultures in 24 hours increase the yield to 94%.
Yep.
Do you concur with that?
So this is a very important question. So the more blood you culture, the more likely you are to grow it in the blood. But having said that, the sensitivity of blood culture is about 40%, as you say. It's about 40%. So we pick up 40% and we miss 60%. So the glucan test is helpful because it picks up some of those additional tests. Some people use the Candida Mahen and anti-Mahen antibodies, and that can pick up a few more. But in a pragmatic sense, a positive urine culture or multiple positive cultures from different sites are helpful. And particularly if you get an unusual species in urine, then that's probably very high likelihood of representing that species causing invasive disease. So the kinocandins cover almost all these strains. There are a few exceptions. Candida parapsilosis is a little bit less sensitive, but it still works. Candida guillemondiae is not quite so effective. And you can get emergence of resistance on therapy, but it's rare. But that's one of the reasons for repeating blood cultures in these patients. Should you give empiric therapy if you're suspicious of the disease? Yes.
Okay. So in addition to this, in addition to the Candida score, our patient has multiple other risk factors for invasive candidiasis. The studies have shown that acute pancreatitis is a well-known risk factors, hemodialysis, central line, immunosuppressions. These are the multiple other risk factors our patient had for invasive candidiasis. So what is the minimum duration of IV antifungal, IV intravenous antifungal therapy for invasive candidiasis? Would you recommend switching to oral fluconazole when the patient is no longer critically ill? Professor Denning?
That's an acceptable practice. I wouldn't give any less than 7 days of an IV antifungal. If you have a susceptible strain, if you have typical albicans and the patient is improving, then I think you can switch at that stage. But if there's any uncertainty, and if you haven't cleared the blood culture, then I think you should continue with IV until that's clear. Candida auris is a pathogen now endemic in India and South Africa in particular. I think you have some cases here because I was talking with Dr. Primmerly about it. That's a more difficult organism because it's fluconazole resistant. Sometimes it's amphotericin resistant or echinocandin resistant as well. So switching to oral antifungal therapy for a strain that's not susceptible is not the right thing to do. And we don't always know that situation. So if the patient's not really doing well, and if you have not changed the catheter, because that's another important part of the treatment, then you should stay with IV, I think.
So these are the take-home messages. So diagnosis of nosocomial pneumonia is often challenging because there are several mimics. So one thing is that, so in a critically unwell patients, there are several mimics like ARDS, pulmonary embolism, heart failure with preserved ejection fractions, or reduced ejection fraction, or airway disease exacerbation. So accurate differentiation between these pathologies is essential for the appropriate treatment. In addition, the decision on empirical antibiotic therapy for nosocomial pneumonia is another difficulty. This is primarily because of the very high antimicrobial resistance, and a significant proportionate of nosocomial pneumonia causing pathogens are sensitive only to polymyxin. So therefore, we sometimes forced to empirically start on polymyxin. This is a challenging decision in patients who are critically unwell with nosocomial pneumonia. And again, the invasive candidiasis is not uncommon in ICUs. So we'll move to the next case. This is again a 64-year-old female who again had multiple comorbidities, diabetes mellitus with suboptimal glycemic control, chronic kidney disease stage 4, is non-atopic asthma, allergic asthma, which is partially controlled on step 4 management of asthma. She presented with a febrile respiratory illness for 2 days associated with increased cough, phlegm, shortness of breath, and wheeze. She was unwell at presentation with very high respiratory rate, increased work of breathing, and she was unable to speak in full sentences. On auscultation, there was bilateral polyphonic wheeze. This was a chest X-ray performed on admissions. It is mostly normal except for some upper zone interstitial changes. His lung ultrasound scan showed a few pathological B lines with diminished pleural slading in the right flaps point. Most of the other areas, it was A profile. His inflammatory markers were perfectly normal at the time of admission. Her influenza A and B antigens were negative. Her renal function was at her baseline, which is 4.1. So what is the clinical diagnosis? Could I ask Bandu sir to answer this question?
Yeah, this is a common problem that we encounter. Asthmatic patients can get a viral infection and they can come with respiratory distress and acute exacerbation of asthma. That is the kind of, I think that would be anybody's diagnosis here, right?
Acute exacerbation of the asthma.
That's right.
So since there was radiological evidence on the lung ultrasound scan, there is evidence of B lines, we thought it's a community-acquired pneumonia. When you have the symptoms of respiratory infections and there is radiological evidence, we thought it's a community-acquired pneumonia, either due to viral or bacterial pathogens causing acute severe asthma, because she was unable to speak in full sentences. She was tachycardic, tachypneic. And she was treated with nebulized bronchodilators, salbutamol, ipratropium, 4-hourly, nebulized budesonide, IV hydrocortisone, which is given at a very quite higher dose, 100 milligram 4 times daily, and IV magnesium sulfate as a adjuvant bronchodilators, and renal adjusted dose of oseltamivir. Though the influenza A and B antigen were negatives, it wouldn't 100% rule out the influenza illness. So we treated her with oral oseltamivir because it was causing an airway disease exacerbations, and her usual inhalers were continued, and we commenced on IV ceftriaxone and oral azithromycin. May I ask this question from Mahen sir. So would you agree with the decision to start on antibiotic therapy when the CRP is perfectly normal?
So now, considering the patient's clinical scenario, yes, but you can't just go only by the inflammatory markers. It has to be inflammatory marker, has to be supplemented with the clinical picture as well. So therefore, I don't think any issue with the starting antimicrobials. Another thing is the CRP is 2 milligrams per deciliter, which equates to 20 milligrams per liter. And it may be in the verge of rising. So if you follow it up with a repeat CRP after 24 to 48 hours, you might see the increase.
I completely agree with you, sir.
Yeah.
On day 2 of the admission, she remained pyrexial despite empirical treatment with this antimicrobial. She was tachypneic, tachycardic, and she was commenced on supplemental oxygen therapy, scale 1, and her CRP increased from 2 grams to 46 milligrams per liter. Her antibiotics were escalated because of the lack of response to the empirical antibiotics. The antibodies were changed to piperacillin tazobactam and IV levofloxacin, and blood cultures were taken. So on day 3 of the hospital admissions, still her pyrexia continued. Her work of breathing and tachypnea further increased. She was commenced on high-flow nasal oxygen therapy due to the increased work of breathing. The microbiologists were consulted, and they said the blood culture didn't isolate any organisms within the first 24 hours. And they recommended changing to meropenem and teicoplanin. And the sputum bacterial culture, normal regional flora in a good quality specimen. The pus cells were more than 25, the epithelial cell count was less than 10. And another set of blood cultures, another 2 sets of blood cultures were taken, and she was transferred to ICU. So you would have seen the initial X-ray. So this is a repeat chest X-ray. There is progression of the infiltrate with multi-lobe consolidations in the chest X-ray. Therefore, we requested a high-resolution CT scan. On day 4 of the admission, her clinical condition further deteriorated. She required emergency invasive mechanical ventilations due to increasing oxygen demand and increased work of breathing. Her CRP increased to 250, procalcitonin further increased to 3, and repeat blood cultures also were negative, and HRCT scan was arranged. This is a HRCT. May I ask Bandu sir to comment about HRCT? Yeah, can we play the CT again, please?
What you see is very extensive consolidations in mainly, there's an abscess in the lower part, left lower zone, peribronchial consolidations, widespread, and in the upper part, in the right upper zone, you saw something like a reverse halo pattern. But considering the rapid onset of the disease and progression, it would go for a staph infection like thing, some kind of organism which can invade the lung quickly and cause lysis and necrosis.
But these patients said the repeated blood cultures were negative, and the sputum also didn't isolate any organisms.
Correct. So in that context, anyway, we can think of fungal infection also because of the reverse halo pattern and peribronchial nodule opacities. But for a fungus, it's too early, and it's very short period. Other than that, of course, tuberculosis is out because it's such a rapid onset disease. TB is unlikely in this situation.
Yeah, play the CT again.
Well, I would be happy to give a good staph agent. You're already on teicoplanin. But then I want to ask microbiological colleagues about whether to treat with the antifungal. If I'm giving antifungal, some broad spectrum antifungal which will cover several fungal infections would be better, I think.
Yeah, so I play the CT again.
Can we stop it in 1 or 2 places? Oh, not yet. Just wait till we get there. Then maybe comment on a couple of the features which are significant. So if you can stop it now.
Can I stop it? Yeah.
Stop. So consolidation with ground glass around the edge, right? But there's also the beginning of ground glass within this large cavity in the right side. So ground glass around the outside can be found with lots of filamentous fungi, but inside it's, as you know, it's called the reverse halo sign, and it's more common with mucormycosis. And on the left side, you can see adjacent to the pleura, you've got an area of consolidation, and you've got a very sharp demarcated line there. And that usually indicates angioinvasion. And so this sharp appearance, which is about 5 o'clock from the mediastinum, there is a very typical for invasive aspergillosis, but it could also be mucormycosis. And then at the bottom of the lung, on the left side, you have this large cavity lesion as well. So it's quite a complex scan, actually. And there isn't a feature which tells you definitively it's this fungus, this bacterium, that bacterium. I think it's quite complex. If you keep playing it just a little more, you'll see this reverse halo appearance on the right lung, where you get this ground glass in the middle. That's what you'd expect from mucormycosis, and this is a diabetic patient. So you do think about that. But there's more to this story than that, I think.
So yes, I totally agree with you, sir, both of you, sir. So here we could see multilobar consolidations, mass-like consolidations, and in addition, there are multiple nodules, and most of these mass-like consolidations and nodules have a ground glass halo. And as Professor Denning said, there is clear reverse halo, which is seen in multiple lobes, so we know. Here we are quite suspicious of an invasive fungal infections. So the problem is there are two different funguses which are more common in patients who have compromised immunity, like chronic kidney disease, diabetes. The two common pathogens, opportunistic pathogens causing invasive fungal disease are Aspergillus and Mucor, where the treatment is completely different, the preferred antifungal of choice. So is it the differentiation of the fungal etiology between these two? Is it possible based on the radiology, Professor Denning?
Put simply, no. And there's two reasons for that. One of them is that the features are not highly distinctive and absolutely differentiated. And the second is that you may have two infections, not just one. So you just because you have one does not mean you have another. And so the issue in this patient is the diabetes was obviously an issue. You've got asthma, but then you had presumptive significant respiratory viral infection as well. You know, we haven't heard the viral results. Did she have influenza or parainfluenza or COVID, or, you know, we don't know that. But we, you know, given the severity of that initial presentation with a normal chest X-ray, yeah, it could well be a virus. It's very likely to be a virus. And there's a strong link between viral pneumonia enough viral lung disease to put you into ICU and invasive aspergillosis. That link is really well established. VAPA, it's called, viral-associated pulmonary aspergillosis.
Yeah, so as Professor Denning correctly says, there are certain clinical and radiological findings which could be distinguished between these two, which should be helpful in distinguishing between these two pathogens, that mucormycosis and invasive aspergillosis. So if you look at the radiology, the presence of nodules, which is more than 10 in number, favors mucormycosis, and the presence of reverse halo favors mucormycosis. And in addition to the reverse halo, the presence of intralobular septal thickening, showing a bird's nest sign, is more suggestive of pulmonary mucormycosis. And in pulmonary mucormycosis, one of the feature which is not seen here is the presence of a larger ground glass halo, larger than the solid component, which would more favor mucormycosis. And the presence of a cavity with the airflow level favors mucormycosis. And as Professor Denning said, if there is a precedent viral infection like influenza or parainfluenza, that would more favor invasive aspergillosis. And the presence of pleural effusion would more favor pulmonary mucormycosis. And the peripheral distribution of here it is primarily axial distribution. If there is a peripheral distribution of the nodules or consolidation, that would more favor pulmonary mucormycosis. So here we couldn't able to confidently differentiate between invasive mucormycosis or invasive aspergillosis from the clinical and radiological grounds. So what is the invasive pulmonary mycosis is the likely diagnosis here. So the additional investigations were requested. So endotracheal aspirates were sent for bacterial cultures, endotracheal aspirate was sent for fungal cultures, and samples were sent for gene expert and acid-fast bacillus staining, and serum Aspergillus galactomannan antigen and Aspergillus specific IgG. So how useful is the Aspergillus IgG and Aspergillus galactomannan in the diagnosis of invasive aspergillosis? Professor Denning.
The antigen test is, serum antigen test is not very useful. It's around 10 to 30% positive in ICU patients with invasive aspergillosis. It's about 10% in COVID aspergillosis, and it's higher in influenza. It's more like 60%. But overall, in ICU patients going into into intensive care with aspergillosis, about 30%. If it's positive, from work from AIMS in Delhi, it has a 90% chance of a patient dying. So a positive test is a poor prognostic factor as well. The Aspergillus-specific IgG has been poorly studied. There's a recent big study from China which looked at this, and they found it as useful as the Aspergillus antigen test, about a 60-70% sensitivity. It was slightly later in the development. It wasn't always positive on the day one of ICU, but it became positive. So it could be a useful retrospective marker. And it was particularly useful in patients with chronic lung disease, COPD patients. It was more often positive in those patients. What's missing here is a bronchoscopy antigen, but this is a critically ill patient, difficult to do a bronchoscopy. But some work from Karachi suggests that you can do an Aspergillus antigen on the ET aspirate or a bronchial aspirate. And if that's very high, like 3 or 4, then that's very suggestive of invasive aspergillosis. But the cutoff is not quite as clear cut for these tracheal specimens as it is from blood and BAL specimens.
Thank you.
In addition to that, when you are testing for these, we have to make sure that you send in a proper container. And there's a possibility that if you use that traditional rubber bung containing thing, and also the environmental contamination, you have to consider that when you are collecting the specimen as well.
So what should be our next step in the management? May I direct this question to Bandu sir?
Yeah, to be on the safe side anyway, I listened to Professor Denny's lecture yesterday also. I think I will go for amphotericin IV in this patient anyway. Adding voriconazole, well, my feeling is I would add voriconazole also, but I don't know. It's for the expert to decide.
I don't think this is pulmonary tuberculosis. So the last choice on there is not something I would do, right? That you can leave that. That can be, think about that later. This patient's not going to live or die with you treat TB today or tomorrow. That's not the issue, I think. Cotrimoxazole, not sure that's useful. This is not likely to renew cystis, I don't think. So I don't think I would be using that. There is some evidence that combination antifungal therapy is better for mucormycosis. So amphotericin plus isavuconazole or amphotericin plus posaconazole. It's a piece of work we published a year ago. It's all retrospective cohort data. It's not a randomized controlled trial, so it's a little uncertain. And so I think if I had enough money, and that is a big issue, I would probably opt for number 3 in myself.
Yeah, so unfortunately, the isavuconazole is not available in Sri Lanka, so it is not in the formulary either. So here we are not sure about the pathogen which is causing the invasive fungal disease. So in which case, so there is a 50-50% probability of this being invasive pulmonary mucormycosis and invasive aspergillosis. would you consider the option of combining liposomal amphotericin and voriconazole for this patient?
We know that voriconazole is about 20% more effective for invasive aspergillosis in terms of survival than amphotericin. So if you think it's aspergillus, you should always use an azole, voriconazole, posaconazole, aviconazole, if you possibly can. But of course, voriconazole has zero activity against mucormycosis, whereas isavuconazole does. It has activity. So that's a big difference between those two agents. We do not think there's any antagonism between amphotericin and voriconazole. It's not been disproven, but we think there isn't. So I think that would, number 4 would be certainly a reasonable position, I think, to take.
So there are some concerns related to the use of voriconazole when there is a suspicion of mucormycosis. And there are some preclinical data which suggest that exposure to the voriconazole enhances the virulence of mucor. Do you agree with that concept?
No. It's really hard to extrapolate from those types of in vitro studies in very carefully conditions into the complex clinical scenario that you have here. So this is a very sick patient. Chance of survival, 5 to 10%. I mean, this is a really severe problem. So I think the concern about the in vitro stuff for me is low on the list.
Okay, thank you, sir. So we initiated him on treatment with liposomal amphotericin at a dosage of 5 milligram per kg as for invasive pulmonary mucormycosis. Unfortunately, the clinical status deteriorated over the next 24 hours and she succumbed to her illness. So in this patient, we used a lower dose of liposomal amphotericin, which is 5 milligram per kg, which is primarily because of the cost factor. And the guidelines recommended quite a higher dose. However, in our experience, we find a good response to even to lower doses like 5 milligram per kg. What is your opinion on using higher doses versus lower doses?
I'm not convinced that higher doses are required for mucormycosis above 5. I think 5 is a good dose. And for aspergillosis, 3 is probably fine. There was a small study which Tom Walsh did where he went to 7.5, 10, and 15 milligrams per kilogram. There was no clear evidence of benefit for a multitude of fungal infections. And there was an RCT comparing 3 and 10 milligrams per kilogram for invasive aspergillosis. And the 10 milligram dose did worse than the 3 milligram dose. So I think 3 or 5 is fine. The only time you might use a really big dose is in leishmaniasis and in cryptococcal meningitis. And those are single doses, large, big single doses. And there will be work coming out for histoplasmosis, I think, showing the same thing. Big single doses, 10 milligrams per kilogram, and then no more. But daily, I wouldn't use more than 5. I think 5 is fine.
Thank you, sir. So on the postmortem, when we trace her blood, her endotracheal aspirate culture, it showed it grew Aspergillus fumigatus and the direxemia was positive for fungal filament. And her serum Aspergillus galactomannan was very high, it was 8.5. Can we be confident about the diagnosis of invasive pulmonary aspergillosis? Could the Aspergillus fumigated isolated in the ET aspirates could be a contaminant or a commensal? Mahen, sir?
Yeah. Again, similar to Candida, isolating fungal filaments in ET aspirate, sometimes it's very difficult to interpret. So as a microbiologist, I would say to go for a tissue diagnosis than isolating organism from tracheal secretion. So because now Aspergillus is all around us. So there's a high chance that you can get a 1 or 2 filament with the granulation of spores. I would happy to go for tissue diagnosis to confirm the diagnosis rather than waiting for the filaments.
Okay. So would it be possible to, Professor Denning, to answer this question? Professor Denning, regarding the isolation of direct filament on the endotracheal aspirates,
yes,
would that increase the likelihood of this being an invasive pathogen compared to the compared to be a commensal or a contaminant?
It's around a 25% predictability for invasive disease. if you take all ICU patients with abnormal chest x-rays, all risk factors, it's about 25% who grow aspergillus have invasive disease. And if you have invasive disease, your mortality is about 100%. So you're going to treat all of them, I think. But you'll be treating 4 times as more than you need to treat. Sometimes it won't be the right diagnosis. And occasionally you have a patient that's just finishing their ICU care, everything's getting better, and they're about to leave, chest x-rays improving, and you grow aspergillus. That patient you might wait and watch, but that's unusual. Can I make a comment about the risk factors? Right at the beginning here, we didn't know whether the patient had influenza or not.
Pardon, sir?
We did not know if the patient had influenza or
Yes.
not. We did not know.
Antigen is negative, but we haven't performed the PCR.
Right. So steroids given to patients with influenza increase mortality. They double mortality. Steroids given to COVID reduce mortality. So knowing which virus it is really important in whether to give steroids or not. This dose of steroid was much too high for an asthma exacerbation, in my view. And we also know that if you have a fungal infection, whether it's aspergillosis, candidiasis, mucormycosis, and you continue steroids, you increase your mortality by 2 or 3 times. So as soon as you think it's a fungus or you have evidence of a fungus, you need to stop the steroids if you possibly can, or bring them way, way down, way, way down. So I think the issue here was the steroids, actually. That's what I think the biggest problem in this patient was. I think that is what caused the problem overall. I mean, I realized that she had diabetes and renal failure and wheeze and all those things, but the steroid dose was really big, and I think it was unnecessarily big.
So the difference between the culture isolations without a direxemia showing fungal filament and culture isolation with direxemia showing fungal filament, is there any difference in the increasing the probability?
Right. Sorry. So if a microscopy is positive, they clearly have infection of the airway, and they may have invasive aspergillosis. So yes, it's almost always highly significant if you see the fungus. Yes.
Okay. Thank you, sir. So this is the European Organization for Research and Treatment of Cancer and Mycosis Study Group criteria. So I think this is primarily intended for cancer patients. It is not intended for non-cancer patients. However, this helps us to understand the basis of diagnosis of invasive aspergillosis. So when we say the definitive diagnosis of an invasive aspergillosis, when there is evidence of tissue invasion of Aspergillus hyphae, or if the blood culture isolate aspergillus, the diagnosis of a probable invasive aspergillosis could be made when the criteria for host factors, clinical and radiological finding, and mycological criteria are fulfilled. So among the host factor criteria, so the prolonged neutropenia, stem cell transplantation, T-cell immunosuppression, and inherited immunodeficiency are included. However, the common host factors that we encounter in our day-to-day practice, like diabetes, chronic kidney disease, are not included in this criteria. Professor Denning, your comment about that? Like influenza A and diabetes, chronic kidney disease, cirrhosis,
correct,
and chronic lung disease.
So there are a lot of factors that are not. These are really for cancer patients primarily and transplant patients. But they don't really work for intensive care very well at all. So I think, and there are separate definitions published for COVID, yes, and influenza-related aspergillosis. And we don't have definitions. Nobody has published definitions for COPD invasive aspergillosis either.
Okay, thank you, sir. So when you only have the host factor criteria and the clinical feature criteria, then you could make a possible diagnosis of invasive aspergillosis. So I think you have answered this question already. What is the role of surgery in the treatment of invasive or chronic pulmonary mycosis? May I ask Dr. Handagala to answer this question?
Thank you very much. Eventually, after 1 hour, I got a question. So, in fact, we are very selective in doing surgery for fungal diseases because unlike in cancer surgery, it is very challenging due to various reasons. Firstly, it leads to a lot of bleeding, and then there are a lot of adhesions. We have to, release the lung from the chest wall, apex. It's a nightmare. And on top of that, as Professor Jennings said yesterday, if we burst the fungal bowl and lead to spillage, again, the outcome of the patient will be very poor if we don't take enough precautions. So the surgery for fungal disease will depend on various factors, whether it's localized disease or whether full-blown disease like the one we saw in the CT scan. We won't touch a patient like this. But if it's localized or confined to a lobe, then we will consider. And again, there are factors like whether the patient has massive hemoptysis, like by definition, they say about 250 ml within 24 hours, or repeated, hemoptysis, life-threatening nature, and then the patient's a lot of hospital admissions and the failed non-surgical treatment like bronchial arterial embolization, and especially the cohort of patients who are immunocompromised, with poorly controlled diabetes or those who are on immunocompromised, we will try to cater surgery earlier, because if we can confine the disease, we may prolong his life. Otherwise, the patient will go into fulminant fungemia later on. He will come to a stage where we can't do anything. And the fungal boards that we see in our part of the world are mostly due to post-TB cavities. And we will consider not to do a pneumonectomy in a fungal disease in this setting, because most of the time, although radiologically we might not see, the changes on the opposite lung, we try our best not to do a pneumonectomy. I don't know whether surgeons in UK would do a pneumonectomy fungal disease unless it's absolutely necessary. And anyway, we'll have multidisciplinary meetings like with microbiologists and then the mycologists and radiologists, the pathologists. And in fact, we will discuss with the patient and patient's relatives, because the outcome of the surgery would be bad compared to cancer surgery. So it's multifactorial and it's always challenging. So not that we don't operate, but we will be very selective in doing surgery.
So the last question to Professor Denning. So how long the antifungal treatment to be continued if the diagnosis is invasive pulmonary mucormycosis? How long the antifungal treatment to be continued with liposomal amphotericin if it is invasive pulmonary mucormycosis?
So normally for mucor, the treatment is between 1 and 2 months long, maybe 3 months long, unless they continue to be immunocompromised. And that assumes that they have good surgery. Sometimes you can't operate. They have bilateral lung disease, or they have disease extending into critical structures, which are difficult. So then treatment would be a little longer. In invasive pulmonary aspergillosis, in those who are intensive care unit patients who then get discharged from ICU successfully, the typical treatment would be about 2 months or 3 months, something like that, because their immunosuppression they're not immunosuppressed. But if they're a transplant patient or they're leukemic, then you would treat for a long time until all of that immunosuppression has gone. And we treat sometimes stem cell transplant patients for 2 years, 3 years with therapy. So it is very individualized, but you would never treat for less than 6 weeks, I think.
Yes, the treatment with liposomal amphotericin for 2 months would approximately cost 5 to 6 million for the country.
Yep.
So my thought was whether doing a surgery would help us to shorten the duration of treatment and save some money for the country.
But it isn't always possible surgery because it's bilateral, because it's too difficult, too destructive. But yes, and that's where posaconazole, zebuconazole, although you don't have the latter, comes in. Although they're expensive too, you can switch to oral and the patient can go home, I think, and that's a reasonable position to take. So maybe we need to advocate for these patients for more posaconazole availability.
Thank you very much. So that brings the end of the case presentation. Now the forum is open for your questions.
For those excellent cases and the panel for a very interesting discussion. My question is to Professor Denning. Does pulmonary mucormycosis occur in isolation, or is it useful to look at the sinuses, also look for rhinosinus disease? And the other thing is, when there is angioinvasion and there is necrotic lung, is there a role for, because these are centrally placed cavitating diseases, is there a place for, if the patient's renal state is okay, is there a place for CT pulmonary angiograms?
Right. So you can have rhinocerebral disease completely separately from pulmonary. You don't have to have the two together. They can They're independent things, and we don't fully understand them. If that I think is your question.
Can pulmonary disease occur without rhinosinusitis disease?
I still don't understand. What did your question? I got the rhinosinusitis. What's the question about it?
Does pulmonary disease occur without rhinosinusitis
Yes,
disease?
yes, that's what I'm saying. They're separate. They're separate. Yes. Sorry, no, I forgot.
Against to Prof. Dennings. First of all, congratulations for organizing this fantastic event. So, what is your experience regarding amphotericin deoxycholate? Because sometimes, most of the time, we don't have the liposomal even. Usually using deoxycholate, and even is very toxic. I feel it's been effective as it is. What's your experience? That's my first question regarding deoxycholate amphotericin in pulmonary mucormycosis.
Right. So I can answer that. So before you go on, so it does work. The dose is 1 milligram per kilogram. Sometimes people use 1.2 milligrams per kilogram. Every dose you proceed with a liter of normal saline, and the normal saline before reduces renal toxicity. And we always give them amiloride to reduce potassium loss and magnesium loss as well. And if they get infusion-related side effects, then we give them antihistamine, a little bit of corticosteroid, hydrocortisone 50 for 1 or 2 days. And if that doesn't work, then a small opioid like pethidine or morphine, a small dose of or opioid. And the real problem is that the renal function gradually gets worse and you run out of space. That's the difficult part. But if you can get the patient over the first 10 or 14 days, giving lots of saline before you give the amphotericin, you may be able then to reduce the dose and be successful. But if it's in aspergillosis, you'll always want to use an azole first, always, because it's better. But for mucor, conventional amphotericin does work.
Thank you, sir. My second question is, I had a personal experience, 36-year-old lady with type 2 diabetes, and she presented with unresolved pneumonia, and bronchoscopy found that he has invasive aspergillosis, and is proven by the bronchial biopsies and all. We started on voriconazole for 6 to 8 weeks. She fantastically kind of improved clinically and sent home. But after 3-4 months, she came again with a relapse, and this time actually that it was mucor. And I always have this question actually, whether you could have given amphotericin in the first instance, but the second sample, she died ultimately. Severe invasive mucormycosis. And do you think it's possible by giving voriconazole initially that could have led to mucormycosis in the second time?
Yes, it's possible. I think these patients do. The MD Anderson looked at dual infections. About 20% of their patients had dual infections. And I think it's maybe one of the reasons why the studies that have shown an improved outcome with combination azole plus amphotericin is partly because you're treating the aspergillosis that's there better, rather than it just being a combination therapy per se in some of the patients. I'm not sure, but I think it's possible.
Yeah, thank you. I got your point. Thank you.
It's regarding chronic granulomatous disease. I don't know whether you have experience of treating patients with CGD. They get invasive aspergillosis, pulmonary aspergillosis. We have patients, but we have never had pulmonary aspergillosis, which is a bit strange. Now, if someone has invasive pulmonary aspergillosis, how long do you treat and how do you treat such patients?
With CGD?
Yep.
Right. So this is, for those of you who don't know, this is an inherited neutrophil oxygen radical failure, the patients that can't kill Aspergillus very well. And they get a very slowly progressive disease, often in bones. It can present in vertebrae or ribs and so on. It's not confined to the lung, so you can get lung disease, which goes through to the chest wall. And you can also get cervical adenopathy and brain disease occasionally as well. It's a slowly progressive disease and it's slowly responsive disease. So it takes a long time to get these patients better. If you were a parent asking me about this, I would say we'd probably be on treatment for 1 or 2 years and maybe a little longer. It's a long show.
Why do you think that we don't get cultures positive or even BAL specimens positive for Aspergillus?
Why are they often negative?
I mean, they're always negative.
Always negative.
We had only one
There's not
patient-
much fungus. If you compare how many viruses there are with influenza, you've got billions of viruses. With fungus, you've got a few hundred cells or a few thousand cells. It's very different. That's one thing. Secondly, the labs tend to use this methodology appropriate for bacteriology. So they dilute the sample, and then they take a little bit and they put it on the fungal plate. If you do a full specimen, you get a bit more. But that doesn't answer the whole problem. I think that the fungus that lives in the lung and adapts to the lung is better working in the lung than it is working on an agar plate. And so I think it's a small volume, a small number of cells, fungal cells, and a not very well adapted fungus for agar plates. I think there's three factors.
So if patients, you can't identify the fungus, but say the serum galactomannan is high, would you treat?
Yes. Yes.
And
I would want to do a second galactomannan because we do have false positives related to food. And this is true for histoplasmosis as well, because histoplasma produces galactomannan and you can detect it. And you can use an Aspergillus antigen to detect histoplasma antigen. Okay, so the same test can be used for both infections. So, but it's found in food. We did some work in Indonesia, all rice, pasta, milk products, they all have galactomannan in them. And in children in particular, they have leaky guts or they tend to absorb these things. And so you can have false positive galactomannan. So I would want a radiological appearance, which was typical. I'd want a sick child and I'd want 2 galactomannans. And then I would say that's the diagnosis.
thank you.
Yeah, so in the interest of the time, we'll close the session.
Thank you for that very engaging and impactful session. Let me invite Dr. Niranjan Dissanayake, President of the Sri Lanka College of Pulmonologists, to present the token of appreciation and certificates to our distinguished speakers and the moderator. On behalf of him, I would like to invite Dr. Upul Pathirila, Honorary Joint Secretary. Dr. M Athavan, our moderator. Dr. Bandu Gunasena. Professor David Denning. Dr. Mahen Kotalawala. Dr. Sumana Handagala. Thank you, sir. We have come to the end of an enriching and impactful first day of ResFire 2025. And I would like to thank our esteemed speakers and honorable chairpersons for their invaluable contribution for this session. A gentle reminder for those who have registered for the workshop on allergy testing, the program will commence at 4:15 p.m. at Ivy Room. So please proceed with that. I extend an invitation for everyone for tea at outside of the conference room. Thank you for your presence and active participation today. We hope you made best out of it. We have an invaluable and highly educational lineup session planned for tomorrow, including pulmonary fungal diseases, critical care, pediatric pulmonology and oncology, and we look forward to a very engaging second day to be held at the same venue at 8:15 a.m. Thank you once again. Hope to see you all tomorrow. Have a lovely day. Thank you.